Hello and welcome to this FERNE presentation. We will be discussing today seizure and status epilepticus patient guidelines, presenting a simple clinical pathway. My name is Edward Sloan. I'm an emergency physician in Chicago. This information was most recently presented at the 10th World Congress in Emergency Medicine in November of 2022. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago in Chicago, Illinois, and I'm Medical Director for the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. I serve as the Medical Director for New Rose Healthcare Management at Roseland Community Hospital, a safety net hospital in Chicago, Illinois. My thanks to the 10th World Congress and mi amigo Carlos Garcia Rosas. He is a great man and a force in emergency medicine. And thank you, all of you who are watching and participating in this educational endeavor. I have no financial conflicts. I serve as the FERNE President and Board Chair, FERNE, the Foundation for Education and Research in Neurological Emergencies, FERNE.org. More about FERNE later. Let's begin with the 2016 AES Status Epilepticus Guideline. This guideline by Glauser and a staff of committee persons provides us an evidence-based guideline for the treatment of patients with convulsive status epilepticus, both in children and adults. This proposed algorithm is provided here in a summary graphic. And from this, we know the interventions are designed for the emergency department, the inpatient setting, the pre-hospital setting with trained paramedics. This graphic comes from Glauser's evidence-based guideline. It includes 4 time periods, and the key concept that drives each of these subsequent time periods is whether or not the seizure or status epilepticus persists. The initial care is consensus-based. The initial therapy is always with benzodiazepines. The second therapies, if required, are up to the provider choice. And the third line therapies are also choice-based and are related to what's available in the system in which a particular provider practices. This again is the graphical representation of the flow diagram or algorithm for the treatment of patients with seizures and status from the Glauser clinical guideline. So again, our clinical setting. These interventions are designed to be implemented in the emergency department in an inpatient setting such as a hospital or in the pre-hospital setting with trained paramedics. The first part of the timeline involves a stabilization phase thought to be optimized during the first 5 minutes of treatment. What's involved with that stabilization phase? First, the patient needs to be stabilized. Airway, breathing, circulation, disability, including a brief neurological exam. Then, it's important that the seizure be timed from its onset during this initial management and monitor the vital signs as the ongoing therapies are provided. Next, assess oxygenation, give oxygen via nasal cannula or mask, and then consider intubation if respiratory assistance is required in order to assure adequate ventilation and oxygenation. Next, ECG monitoring is recommended. Next, a fingerstick blood glucose should be determined. If the glucose is less than 60 milligram percent, then in adults, 100 milligrams thiamine IV and 50 milligrams of D50W is provided IV. In children greater or equal to 2 years of age, 2 milligrams per kilo of D25W IV, and in children less than 2 years of age, 4 milliliters per kilo of D12.5W is provided IV. Lastly, attempting an IV is critical in order to collect labs for electrolytes, hematology, toxicology screening when appropriate, and anticonvulsant levels if clinically indicated. If following the first 0 to 5 minutes of patient stabilization, which understandably could take longer than 5 minutes. If the seizure continues, then the protocol suggests that the provider should continue to the initial therapy phase for the treatment of patients with ongoing seizures and status epilepticus. The timeline for this phase is 5 to 20 minutes. This initial therapy phase then should take approximately 15 minutes overall. We know that a benzodiazepine is the initial therapy of choice. There's level A support that suggests always when treating with an anti-epileptic drug, the first therapy should be a benzodiazepine. And there are 3 options, each thought to be equivalent in their ability to treat a patient with seizures or ongoing status epilepticus. The first is intramuscular midazolam. An initial dose could be 10 milligrams for any patient greater than 40 kilograms IM, and for children 13 to 40 kilograms, a 5 milligram IM dose in a single dose is recommended. There's level A support for this recommendation. A second benzodiazepine option is intravenous lorazepam when IV access is available. The dosing is 0.1 milligram per kilo per dose, a maximum of 4 milligrams per dose, suggesting that the dose could be repeated 1 time. There is level A support for this in this particular guideline. The third option is intravenous diazepam at a 0.15 to 0.2 milligram per kilo dose, a maximum of 10 milligrams per dose, suggesting that it could be repeated times 1 with level A support. If none of these 3 options are available, IM midazolam or IV lorazepam or IV diazepam, there are other options that are available during this initial therapy phase, understanding that the benzodiazepine is always preferred. But if those are not available for any reason, intravenous phenobarbital can be given 15 milligrams per kilo per dose as a single dose with level A support, or rectal diazepam 0.2 to 0.5 milligrams per kilo, maximum of a 20 milligram dose as a single dose with level B support, or intranasal midazolam or buccal midazolam, both with level B support. If at the end of this 5 to 20 minute phase, which understandably could take a short amount of time longer, if the seizure and status epilepticus persists, then it's important to continue to the second therapy phase. The second therapy phase is intended to occur between 20 and 40 minutes. When discussing medications, anti-epilepticus drugs that can be provided during this second therapy phase, there is no evidence-based preferred second therapy of choice, so the level of support is undetermined. So, since there is no preferred second-line medication to be provided, any one of these can be chosen and given as a single dose. The first is the option to give intravenous fosphenytoin at 20 milligrams of phenytoin equivalents per kilo. The maximum dose is 1,500 milligrams PE per dose, again without support that this is superior to other therapies. If fosphenytoin is not available or preferred for some reason, the next option would be intravenous valproic acid or valproate, 40 milligrams per kilo, maximum dose 3,000 milligrams per dose with level B support, or intravenous levetiracetam, 60 milligrams per kilo, maximum dose 4,500 milligrams per dose with level U support, again suggesting this is not known to be superior to other second therapy medications. Now, if none of the above options that we mentioned are available, that would be fosphenytoin or levetiracetam or valproate. Then there is an option to give intravenous phenobarbital, again 15 milligrams per kilo, maximum dose, with level B support for its efficacy for ongoing status epilepticus. At the end of this 20-minute period, which understandably could take a short amount of time longer, if the seizure continues, then it's important to continue to the third phase of treatment. The timeline for this third phase is approximately 40 to 60 minutes, a 20-minute period during the third phase of medications. As with the second phase of anti-epileptic drug therapies, there's no clear evidence to guide any single therapy as being superior to another, so the level of support still remains undetermined. The choices include repeating whatever second-line therapy was provided in an additional dose, or to provide anesthetic doses of thiopental, midazolam, pentobarbital, or propofol, understanding that if any of these third phase medications are provided, it's necessary to provide continuous EEG monitoring, because with these medications, patients will be unresponsive. It will be impossible to determine whether or not there's subtle status epilepticus ongoing, which is ongoing brain seizure activity without any motor manifestations that are noted clinically. On this slide, which again summarizes the clinical guideline from AES by Glauser et al., we can see that over a 60-minute period, it is intended that optimally a patient during the first 5 minutes can be stabilized. If seizures continue during the next 15 minutes, initial therapy with any benzodiazepine options is suggested. During a 20-minute second therapy phase, additional medications can be given based on the ability of any individual institution and provider to give this therapy. And during the last 20 minutes would be a third phase of anti-epileptic drug therapy for patients who have ongoing seizure and status epilepticus. It is understood that it is a 60-minute time period during which optimally the status epilepticus is terminated, because it is known that beyond 60 minutes, the mortality from status epilepticus is quite high, and that's either related to the seizure itself or the cause of the seizure, which may carry with it a high morbidity and mortality. Again, this is a graphic of the proposed algorithm from the Glauser Epilepsy Currents publication in 2016. And from this, we know that it's applicable to most all settings where they're trained providers. We know that the evidence in the guideline is for the most part not strong, except to say that benzodiazepine should be the initial therapy of choice. We know there are 4 time periods, and it's important to start the stopwatch the minute the patient arrives or begins to have the status epilepticus episode in whatever clinical setting. We know that subtle status epilepticus is a concern, and that if you get to the third phase of treatment, it's necessary to provide ongoing EEG monitoring to exclude subtle status epilepticus. We know that the initial care is consensus-based, that is to say, the initial resuscitation is similar to the resuscitation of all patients who present in extremis, whether or not it's related to status epilepticus. We know that our initial therapy is related to the benzodiazepines, and that lorazepam is the preferred IV medication when available. We know that the second-line therapies, when indicated and necessary, require medications that should be available either in the emergency department or whatever critical care setting in which status epilepticus might need to be treated. And we know that once third-line therapies are provided, that ongoing EEG monitoring is necessary to exclude subtle status epilepticus. That ends our discussion of the 2016 AES clinical guideline for the treatment of children and adults with status epilepticus, ongoing seizures. Thank you for taking the time to learn more about the treatment of patients with seizures and status epilepticus. For more information, please go to the FERNE.org website. And also, please subscribe to the @FERNE.org YouTube channel. We encourage you to go to all of our social media sites to obtain or to learn what are the most current optimal therapies for the treatment of patients with any neurological illnesses, injuries, and/or emergencies. FERNE.org. If you have any comments or questions, don't hesitate to email us at fern.org@gmail.com. I'd like to thank you, and Ken Moore, listed here on the left, also thanks you for your time and efforts on behalf of patients with emergency illnesses and injuries related to neurological diseases. Once again, Edward Sloan, thank you.